Hi there, my name's Adam Cohen. I'm a myeloma physician and clinical investigator at the University of Pennsylvania in Philadelphia. And I'm here today to talk about my late-breaking abstract, which is exploring the use of a new drug called Cevostamab after CAR T-cell therapy for patients with relapsed refractory myeloma. So Cevostamab is what we call a bispecific antibody. So it's a novel way to activate the patient's immune system by trying to wake up their own T cells to get them to attack the myeloma. And Cevostamab is different than some of the other bispecific antibodies that are already out on the market in that it hits a really new target on the myeloma cell that's called FcRH5. And FcRH5 can be expressed on myeloma cells, in some cases even if they've lost some of the other targets that we normally go after. And so this trial is designed to see for patients who are getting BCMA CAR T-cells, which are our FDA-approved CAR T-cells, which we know are very effective, but unfortunately many patients still unfortunately relapse. The idea here is they get their BCMA CAR T-cells, and then we come in about 2.5, 3 months later with the Cevostamab drug to try to reactivate those T cells to now attack a different target on the myeloma. So the idea is it hopefully will keep the myeloma from trying to escape the treatment by hitting it at two different ways, by hitting two different targets. And so this was a small pilot study that was done at the University of Pennsylvania, and what I presented was some preliminary data, just looking at safety and some early efficacy. We've enrolled 27 patients so far on the study, and these were all heavily pretreated patients. They had had a median of 4 prior treatments and had gone through a lot of the standard drugs that we use for myeloma, such as the proteasome inhibitors, IMiDs, and daratumumab. All of them got a CAR T-cell therapy, and then they started on the Cevostamab for up to 8 cycles, which was 24 weeks or 6 months. And the drug is given as an IV infusion. Like most bispecifics, there's a small step-up dose, and then a week later you get the full dose and continue every 3 weeks. And then if you're in a really good response after the 8 cycles, you can stop. If there's still any residual disease, you get 8 more cycles of treatment. And what we found so far is that it appears to be safe and feasible. The vast majority of patients are able to get through the 8 cycles of treatment. We have seen some low blood counts, but overall the risk of infection, which is what we always worry about with these drugs, was relatively low. Only 15% had what we call serious or high-grade infections. And importantly, we saw very little of the cytokine release syndrome, this sort of overactivation of the immune system that you can see with these drugs. That was only seen in 15% of patients and seemed to all be low-grade and resolved quickly. And in terms of early efficacy, the follow-up's relatively short, only about 12 months, but so far we've only had 1 patient progress, and over 90% of the patients so far are sort of alive and still in remission a year out after the CAR T-cells, and over 90% are in what we call MRD negative, or minimal residual disease negative complete response, which is really what we're trying to get to, because we know if we can get people to that really deep remission that has been in other studies predictive of these long-term remissions that hopefully will last for many years. So I'll say it's early days. We really need longer follow-up. We're still treating a number of patients, but I think it looks promising so far, and hopefully I'll be able to give an update maybe a year from now and let you know how things are going.